welcome everybody. Thank you for coming. My name's Andrew Hydra. I'm a consultant clinical and forensic psychologist and approved clinician, and I work as clinical director for Ludlow Street Healthcare, and we're a medium-sized provider within South Wales and the southwest of England for people with significant mental health difficulties and learning disabilities. So we run a number of inpatient sites and a lot of social care sites as well. I'm really grateful for the opportunity to be able to talk about this today, because it was one of my huge concerns really at the beginning of the pandemic, in regard to how we were going to preserve the rights of our service users throughout the period. So what I'm going to do is going to go through, and this is very much a presentation about actually what happened. So I'm going to try and focus on real events here and case studies that sort of resonate with the theme of what we're talking about today. And I'll just try and whiz through as quickly as I can and not kind of pad it out too much, because there's quite a lot of detail in what I'm going to say. So the first thing is that, you know, we need a set of references to manage a pandemic, I guess. And as mental health clinicians, you know, we have, as Dan and Kevin have both mentioned, existing codes of practice. So we have the Mental Health Act code, we have the MCA code, and obviously we've got the Human Rights Act. And of course, none of those were actually designed to help mental health services navigate a global pandemic. They didn't have that in mind, and they've kind of come up against this operational and clinical situation, you know, we found ourselves in. So, you know, I found myself kind of going back really in terms of a general knowledge of ethics as being very important in clinical practice. You know, how we behave as clinicians, particularly when we coerce people, is a reflection of the ethical assumptions of the society in which we live. And sometimes those assumptions require challenge. So I think it's just about being aware. And I was sort of reflecting on this a lot during the pandemic, because I worked all the way through clinically. You know, what was informing my thinking about the decisions that I was making? And really, we've been up against some pretty profound, you know, questions about the relationship between individual rights and the state. And also, you know, very profound questions about the ethical nature of humans and, you know, human rights. And, you know, what are they? What are human rights? And I think, you know, those questions are things that can seem very abstract, but in the context of actually, you know, running and managing complex mental health services through this period have become extremely concrete and real. You know, so what were we worried about at the beginning of all of this? Everything really that Dan and Kevin and Andy have referred to. So, you know, clinical cover, you know, would we have enough staff? Clinical governance, you know, upholding patient safety requires people to think in a slow way. You know, we were concerned that if we just started focusing on COVID and neglected our general governance, that would compromise safety and quality. We were concerned about right to family life, people losing access to their family via bans on visits. We were concerned that mental capacity wouldn't be considered in our inpatient services as a factor in supporting people to make decisions. And we were also concerned that, given that everybody's anxiety had gone up so much, that our rates of restraint and physical intervention would increase. So those were our worries in our inpatient services. In social care services, very similar in terms of clinical cover, in terms of clinical governance, in terms of right to family life, mental capacity. And in terms of restrictive intervention, we were more concerned about restricted practice within social care. So, you know, people not being able to do things that they should be able to do, and based on assumptions that they were unable to make decisions for themselves rather than proper capacity assessment. So those were our concerns at the beginning. So what we did, I'm going to whiz through this. This kind of gives an overview of what we did. And I think it's fair to say, you know, lockdown was a predictable event, really. We were planning at the end of January for significant social disruption from the pandemic. So we constructed a concern list across all of our services of people who might struggle to understand or engage in increased restrictions. We created care plans for everyone in partnership with service users to prepare for those. We developed clinician cohorting lists. We constituted standard operating procedures for all of our separate services and ensured that the principles of the MCA code and the MHA code were incorporated into those. We directed the continuity of clinical governance and sort of separated that off from our strategic thinking around COVID in order to ensure that normal clinical governance was maintained. And really importantly, we directed the continuity of our corporate clinical ethics committee and emphasised to all MDTs that they should be making full and frequent use of that. We raised some concerns externally about the pivot of restrictions towards elderly social care with some of the government guidance that was coming out. Wasn't always appropriate for our tertiary mental health service users, and I think that's a difficult issue, but we did raise it. We preserved on-site working for our clinicians. We didn't work from home. We communicated with all families, carers and service users to support video communications. We directed that all service users must be offered a care plan with timed regular family contact. So rather than just say, yes, we will help you use video to contact your family, we made sure that there was a care plan with a specific time to ensure that it wouldn't get kind of overlooked. And we did a lot of purchasing of additional IT facilities. So that's kind of what we did. Now, in terms of what happened, there were a few case studies really that I thought that would be helpful to kind of talk about, which I suppose highlights really the sort of human rights and ethical concerns that we've all been grappling with. So first of all, we received a directive from Welsh Government. You can probably tell from my voice that I'm speaking from Wales, advising all transitions to social care sites from inpatient services must self-isolate even if they'd had a negative test for COVID and they were being discharged from a COVID-free hospital to a COVID-free social care site. So immediately we were concerned about the lawfulness and the rights compliance of that, given that these were people who'd had a negative test. Obviously that balance between risks to mental health and the right for somebody to only be detained in a hospital if they absolutely have to be with COVID risk. And we felt it's a sort of balance between Article 2, right to life, and Article 5, the right to liberty, was important. So we escalated to Public Health Wales to raise those concerns about the fact that we may be in a position to follow that guidance of using restrictive intervention, unlawfully, and creating risk. And Public Health Wales agreed to review a protocol that we wrote to support decision making when discharging people. And that protocol balanced rights, capacity, and risk to the person of restrictive intervention if they didn't isolate, even though they were COVID negative. And that was signed off and agreed by Public Health Wales. So it's a very helpful kind of joint decision. And we've been meeting weekly with Public Health Wales throughout this as an organisation to run all these ethical issues past them. The next one, somebody subject to a DOL authorization, hadn't had family contact for months, inability to adhere to distancing and PPE for that particular individual. We were very concerned again around the impact on that person's mental health. Again, we discussed with Public Health Wales to ask if we could put in place a specific risk assessment around a potentially non-distanced visit. Again, that was reviewed, signed off, and the family visit took place. So this was just a kind of a process that we were going through very regularly in ensuring that we were raising concerns, reviewing individual risk assessments, and then taking decisions that were hopefully in the interests of the people that we were supporting. Finally, towards the end of the lockdown, the initial lockdown, the police stopped one of our staff teams who were on a therapeutic drive with a service user who just couldn't cope with interruptions to routine and were advised they were in breach of guidance. And at that time, the College of Policing had actually put out guidance saying that visits such as that should go ahead. So we contacted the police and advised them of their own guidance, and then those further trips were not stopped. So, where are we now, I guess, in terms of thinking about, the situation in the mental health system as we move into probably another difficult few months? The ship didn't sink, but, we're in the Strait of Messina, if people know the myth of Scylla and Charybdis, between COVID-19 and human rights infringements. We have operational and clinical protocols that are protective of rights in place, and we can flex those up and down. But the current risks, as I see it, having been through this, is that a further period of high community transmission, there's a lot of human factors for all of us as sort of workers, leaders, service users, that bear down on these sort of rights abuses that we're vulnerable to. So one is very sort of unthinking obedience, really, to any guidance that comes out. Fear-driven reasoning is obviously extremely dangerous when it comes to making decisions that impact on people's rights. Fast thinking generally, so not taking the time to actually think about what you are doing and what rationale you have for making your decisions. And we need to be careful that negative freedoms, freedoms keeping people free from things or risk, overwhelm positive freedoms, which is maintaining people's freedom to do things. So just to finish off, really, a helpful view of human rights for mental health in a pandemic. We've not thought about this before, probably most of us, but I've been thinking about it a lot, and I'm sure all the rest of us have. And I am going to lapse into this last slide, I'm sorry, into some sort of formal ethical jargon, so I apologize for that. But human rights, as we talk about them, are based on underlying assumptions of what we call deontological ethics, which is that there are these absolute moral laws that define what is right and we have to follow them. But in a pandemic, our clinical decision making is driven by this sort of consequentialist reason, so sort of thinking about what are the consequences overall for the decision. And sometimes, and government obviously works in this way a lot, is thinking about utilitarian decision making. So what are the competing outcomes for the individual against the overall outcome for society? So I think, for us as in mental health services, that we might usefully see ourselves as having constraint-based responsibilities as clinicians and leaders. So this is about ensuring that we exercise the responsibility of our duty to intervene, to provide treatment and care for people's mental health problems, while being aware of what of the constraints posed by the additional ethical calculus, as I'd call it, of a pandemic around us. And the day-to-day decisions that we have to make are about the reasonableness and lawfulness of the constraints that are placed upon us as clinicians, as leaders, and more importantly on the people who use our services by the pandemic planning guidance that is obviously not necessarily been pivoted around the needs of the mental health system. So I think it's just about being aware, really, what are our duties in terms of how we apply these, constraint-based responsibilities that we have. So ensuring our staff are aware of what the articles are of the Human Rights Act and can either give a rationale for decisions based on them, or they can tell other staff about why the decision that they've directed must be followed under human rights law. The need to challenge authority, and I would include public health bodies in this as mental health clinicians. Public health protocols may represent reasonable constraints on rights, but not for others. And that might be within the same service. So emergency rules may not be either lawful or ethically reasonable. And also to be aware that ethics and emotional responses are linked. So our ethics derive from our natural human group behavior and our emotional functioning. So I think it's probably fair to say to colleagues, if a clinical or a service decision feels wrong, even in the context of a pandemic, it may well be simply wrong. That's it.